Hey guys, welcome back to Man Medicine, where we talk about how men can optimize their health and avoid the collapsing U.S. healthcare system. And let me tell you, is it ever collapsing? I just got back from a string of night shifts, and I'll tell you guys, 2 years into this corona thing, things are not looking good. The department was completely full. We had not a single open inpatient bed in the entire state. And so I was taking care of people that in some cases had been some very sick people who had been sitting in the emergency room for 2 or 3 days waiting to get an inpatient bed somewhere. People that were sick enough to be in the intensive care unit. So heart attacks, strokes, sepsis, etc. No place to put these people. So guys, you don't want to get sick. You don't want to get sick these days. You need to stay out of the U.S. healthcare system. And the only way you can do that is to get yourself as healthy as possible. So anyway, that's not what I want to talk with you guys about today, but I did have an interaction with a patient that prompted me to make this video. And what we're going to do today is a little bit of myth busting, and specifically we're going to talk about statins and erectile dysfunction and statin medications related to low testosterone. So in the middle of one of my night shifts, I was just getting crushed. I had a guy come in his, I think he was in his mid-50s. He'd been having chest pain. 6 months prior to this, he'd had a heart attack, and he'd had I think it was at least, he had one stent placed. But I looked at his angiogram, and he had another significant lesion that cardiology wanted to stent in one of his smaller, he had I think it was in his circumflex artery, but because of how tortuous his particular artery was and the location of this plaque, it was not something that they could intervene on, and apparently was not also amenable to a bypass surgery. So he did receive his one stent, but he still had this vulnerable plaque, we should say, in his circumflex artery that was going to be managed medically. And so medical management for stuff like that involves, obviously aggressive risk factor modifications. He was on a beta blocker. I looked through all of his meds list like I do with every patient. He was on a beta blocker, which was appropriate. He was on an ACE inhibitor, which was appropriate. He was on an antiplatelet agent, which was appropriate given his recent stent. Now, he still was obese. He still was sedentary, and he still smoked. Okay, so there's only so much that these medications can do when you continue to live that sort of lifestyle. But one of the things that was conspicuously absent in this guy's medical regimen was I didn't see that he was on a statin, which is pretty standard once you've had a heart attack. There's good evidence that at least initially after a myocardial infarction, that a statin is something that can generally benefit you. And in particular, this guy with this vulnerable plaque, which was not amenable to any sort of intervention, I would have thought that, this guy, if anybody needs to be on a statin, it's this guy. And now the point of this video, I'm not going to get into the debate about statins, pros and cons. I am neither pro nor con in terms of statins. I prescribe statins. I do them on an individual basis, and I do it based on a person's individual risk, their family, particularly their family history, what their lipid numbers look like, and also what some of their goals are. So I don't want to touch that issue, but I want to talk about why this guy was not on a statin, because I asked him about it, and he said, "I don't want to be on a statin because I don't want to get erectile dysfunction." Okay. And, he said, my doctor tried to talk me into it, but, I've read about these drugs. I don't want to take them. And I'm not worried about any of the other side effects per se. I'm paraphrasing here, but he was worried about getting erectile dysfunction. So, okay. So that's why he was on a statin. So one of the unfortunate things about working in this ridiculously busy medical environment in the emergency room, it has really changed, is that I don't have time to sit down and talk to patients like I used to kind of explore that issue with them. And, I don't have an agenda to push a statin on this guy, but when I do come across patients that I think are, who have gotten bad information about anything in the medical world, I like to talk to them about it and kind of see where they're coming from. And if I have an opportunity to educate them, I'll do it. unfortunately these days, I am just too goddamn busy. At any particular time, I'm managing between 8 and 15 patients. I am going room to room. My hair, if I had any, is on fire like every shift. So, I didn't really have time to sit down with this guy and talk about this, but I thought I would take the opportunity to talk with you guys about it, in case you've heard similar things, and in case that's the reason why you may not want to take a statin. So, so let's look at the literature about this. Let's talk about the erectile dysfunction issue first. I pulled up a couple studies here that I want to just briefly review. Again, I'm not intending this to be a comprehensive review on statin medications, but this review here from the Journal of Andrology, it's called Statins and Erectile Dysfunction, a critical summary of the current evidence. And this is a meta-analysis, and what they did is they looked through a bunch of different studies that examined this question and said, okay, is there something to this? And I'll cut to the chase here. I'll read the conclusions. It says, the prevalence of evidence reveals that the pharmacological use of statins for the treatment of hypercholesterolemia improves the quality of erections in patients with erectile dysfunction. Okay, statins don't make ED worse. They have the potential to actually make it better in most of the studies that are out there. So why is this? Well, statins have benefits that go beyond their lipid lowering capabilities, and so they have these things they're called pleiotropic benefits, and that includes lower amounts of high sensitivity CRP, which is a measure of inflammation, improved endothelial function, etc. And so that's one of the theories that they mentioned in this article, that they say here. The potential mechanisms that explain the positive effects are increased bioavailability of nitric oxide. Nitric oxide is absolutely crucial for relaxation of the penile vessels to allow adequate blood flow. If you don't have adequate nitric oxide, or you have diminished ability to respond to nitric oxide, like in the setting of endothelial dysfunction, this is something that a statin might be able to help with. Okay, so increased bioavailability of nitric oxide, enhanced plasma nitrite to nitrate concentrations, similar thing, and then normalized Rho-A and ROC2 overexpression in the corpus cavernosa. You don't need to know what that is. These are enzymes that are part of a signaling pathway. They phosphorylate. They're enzymes that phosphorylate other molecules, and they're called kinases, and they are involved in cell signaling. They're very important. Statins seem to help with that. Okay. Now, in this study, they did find a few studies. There was definitely the minority where there seemed to be a signal that, okay, maybe there is something to, maybe some patients do get erectile dysfunction. But the overwhelming number of studies in here, and their ultimate conclusion was that statins do not cause erectile dysfunction. But they mentioned something down here that we're going to talk about. It said, finally, among the negative aspects, the potential reduction of serum testosterone levels observed in statin users deserves further studies. And it has been studied further. We're going to talk about this, and might explain why other studies have reported reduced erectile function in men taking statins. Okay, again, the vast majority of studies show that it does not reduce or cause erectile dysfunction, and in fact improves erectile dysfunction. And this also makes sense. If you guys recall from one of my previous videos, the most common cause of erectile dysfunction in older men, all right, it's vascular. Okay, it's progression of atherosclerotic disease. Okay, cholesterol plaque in the penile artery and other vessels of the pelvis that limit blood flow to the penis. Okay, so if you continue to have worsening atherosclerosis, your erectile dysfunction is just going to continue to get worse. And I'm not saying that statins are the only thing that you can do. They're just one. They're one. I guess, arrow in your quiver in your approach to prevent atherosclerosis and prevent it from progressing. So let's talk about this serum testosterone thing. Where does this come from? So there are some literature out there that have shown, and I'll go over the studies here, that there in some cases is some effect. It's a bit controversial, but some effect on total testosterone levels. And Unfortunately, there's a number of semi well-known physicians out there that are very anti-statin. And I came across a video by this guy. His name's Dr. Ken Berry, who actually I like his channel. He's a family physician, and his brand is essentially around ketogenic diets. It's built around, he's a proponent of the carnivore diet, both of which I have no issues with at all. I love a ketogenic diet for myself. He tends to play it up a little bit as like the cure-all for everything. In my opinion, it's not. But he's got a great channel. He's got millions of followers. I do think he oversimplifies things a little bit. But I think he does that. I think he does it intentionally because his channel is geared towards the lay public. And, let's face it, these are complicated issues. They have a lot of gray areas. There's a lot of nuance in there. But most people that are trolling through YouTube that just want to get a little bit of information, they're not interested in hearing about nuance. They're not interested in hearing about, gray areas. They like things. This is how it is. This is what you need to do. And don't think too hard about it, okay? So some of his videos are like that. But again, I'm not disparaging the guy. I like him. I think if you have metabolic syndrome, diabetes, prediabetes, if you have heart disease, if you follow his advice, you certainly you'll do fine. You'll do fine. So anyway, not that you're going to listen to this, Dr. Berry. You're a good guy. I'm not disparaging you. And I think people should check out your channel. But he's very anti-statin. And I came across one of his videos where he ran through all of the side effects of statins, and he was right on all of them, with the exception of low testosterone. So, and I want to talk about that a little bit more. Statins do have side effects. I think the side effects are largely overplayed, overestimated. There's good data to support that. The overall side effect profile of statins is not really much worse than with placebo. Having said that, I have had a number of patients over the last 20 years that have been very much statin intolerant, who have developed clinically significant myositis. Again, these are rare. I can count them on one hand. The number of patients that have had, genuine issues like that, but they do exist. And, if you've had a problem with a statin, I'm not here to tell you you're crazy or that you imagined it. I know that I believe you. Okay. So, but let's look at this testosterone thing specifically, because, again, my patient, that I talked to, if anybody could benefit from a statin, it would have been this guy. But he was deathly afraid of getting erectile dysfunction. And he is focused on the statin as being something that could cause that. Obviously, people are not always rational, and he wasn't worried enough about his smoking to quit that. Because obviously smoking is probably the number one thing that's going to give him erectile dysfunction. He wasn't worried about his obesity causing erectile dysfunction. He wasn't worried about his diabetes or prediabetes, any of that stuff, or his coronary artery disease. But God forbid I take a statin. Anyway, so this is let's look at this first one here. So this is a Cochrane review, and Cochrane is it's a group that reviews medical literature and comes out with consensus statements, and they do their best to provide evidence-based answers to clinical questions. And this particular one is called the effect of atorvastatin, which is one particular statin on testosterone levels. So they only looked at atorvastatin. There are obviously other statins that are prescribed. They all work in a similar way, but they have different half-lives and different side effect profiles. And if we cut down to the bottom of this, this is their conclusion. We found no significant difference between atorvastatin and placebo on the levels of total testosterone in males. Now, actually, in women with PCOS, which is a subset of people that they studied here, there actually was an effect. But again, if you're a female with PCOS, this is actually a benefit, to lower your testosterone levels. But in men, in the studies with just looking at atorvastatin, no significant difference whatsoever. Okay, so I dug a little bit deeper, and it turns out, like with everything, I mean, there's nuance here, and there are dissenting views. The medical literature is rarely in lockstep and crystal clear on any particular issue. You can find studies that will support almost anything that you want to support. So you have to be careful about that. So this one is from the journal Diabetes Care. It's called "Statin Therapy is Associated with Lower Total but Not Bioavailable or Free Testosterone in Men with Type 2 Diabetes." So this is a pretty cool study. In this particular one, there was a drop in total testosterone, and it was about like a 50-point drop in total testosterone. But there was really no significant change in the free testosterone, which, as you guys know, because I know you're smart, that's really what matters, is your free testosterone. The other thing to keep in mind here, a 50-point drop in total testosterone, I mean, who cares? Is that likely to be clinically significant? I think highly unlikely. The reason I say that is in men, we have this, it's called a diurnal variation in testosterone, where testosterone levels, they will vary from day to day. And that's why if you've had your testosterone levels checked on different occasions, if you're not on TRT, you'll get different numbers depending on the day. And it's going to be higher in the morning, it's going to be lower in the evening in general, until you get to be much, much older, and that kind of smooths out. So it is not uncommon to have 50 to 100 point swings, especially in a younger person, in their testosterone. And they are rarely, if ever, of any sort of clinical significance. So in this study, a 50-point drop in testosterone, I mean, it's not clinically relevant, in my opinion. Okay, and that's supported by this other study here. Okay, do statins lower testosterone? And then here's the $1 million question: and does it matter? Now, in this particular study, they looked at several different statins, and some studies showed no effect. A couple studies actually showed that testosterone went up, not very many, but the net effect was a slight decrease in total testosterone. And in this particular study, it was about a 19 to 20 point drop on average, after they collated all these different studies in total testosterone. They actually didn't look at free testosterone in this one. So again, a 20 point drop in total testosterone, highly unlikely to be clinically relevant. Okay, and if you're a patient like the guy that I took care of the other night, who is at very high risk for another heart attack. I mean, he has a high risk lesion. He has vulnerable plaque. He has multiple cardiac risk factors. Again, if anybody would benefit from a statin, it's this guy. And to withhold or to refuse to take a statin solely for the reason that you're worried about getting erectile dysfunction, or solely worried about this microscopic, clinically irrelevant drop in total testosterone, I think that's a poor choice on his part. And again, I wish I had time to sit down and talk with him about this. Not to change his mind, but just to educate him a little bit, just to give him the information. I rarely tell patients what to do anymore. I just kind of stopped doing that. But what I do when I can, especially in my men's health practice, is I want to give my patients all of the information possible. Pros, cons. We do go into the nuance and the gray areas, because again, these things are not black and white. And then, you know what, I trust my patients to make good decisions, but you can't make good decisions unless you have all of the available information. Okay, so you have to know both sides of this issue before you can make in my opinion, a reasonable decision about what your course of action is going to be. So anyway, I don't want to go too much further into this, but again, the notion that, first of all, that statins cause erectile dysfunction, that is false. That is false. I don't care what anybody on the internet says. It's just not true. It's just not true. The effect on testosterone, it looks like if we look at all of these studies grouped together, there is a very small drop in total testosterone. There appears to be no significant change in free testosterone, which again, that's what really matters, right? So again, that is, in my opinion, not a reasonable reason to avoid a statin, especially if you're a high-risk person. Now, if you're a low-risk person and we're talking about primary prevention, you need to sit down and have that conversation with your doctor. You need to look at your family history. You need to look at your lifestyle, that sort of thing. But if we're in the realm of what they call secondary prevention, where you've had a heart attack already, we know that you've got clinically significant atherosclerotic disease. And in particular, if you have vulnerable inflamed plaque, I don't know. If it was me, I would take a statin. I don't take one currently, but God forbid down the road, if I ever end up with, clinically significant heart disease, which is rampant in my family, I would absolutely take a statin, and I would not be worried about some of these other effects. Okay, so that's all I have for you guys today. Let me know in the comments what your experience has been with statins, and let me know if you've had erectile dysfunction and you think it's related to a statin. I'm always interested in hearing anecdotes. The medical literature is the medical literature, but at the end of the day, we are all are individuals. People do respond differently to different medications. And so if you've had a negative or a positive experience, let me know. In the meantime, I will catch you later. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.